I'm going to share my slide now with you. Uh, Just kindly let me know that are the slides visible presently?
Yes,
Yes,
yes.
sir. Yes.
Okay, we'll just start. Just a brief introduction about Parkinson's disease. So, what is Parkinson's disease? So, Parkinson's disease is a neurodegenerative disorder. Neurodegenerative means certain kinds of diseases where there is degeneration of the neurons, of the predominantly of different cells of the central nervous system, and which results to the clinical symptoms of this disorder. And Parkinson's disease is the second most common neurodegenerative disorder in the world. The first being Alzheimer's disease. You might have all of you might have heard the name Alzheimer's disease, and Parkinson is the second most common. And it very commonly involves the elderly population. The age more than 65 years is the most common age group where this disease is primarily seen. But there is a very common myth that it cannot affect young patients. So through this, I would like to clear that it can definitely affect young patients. And we have a term for the patients who get afflicted by this disorder less than 50 years. We call them young onset Parkinson's. So any patient having Parkinson's disease less than 50 years, they come into the category of young onset Parkinson. And patients can also develop this disease as early as 20 years of age. So less than 20 years, they are called as juvenile Parkinson's disease. But definitely, as the disease, as the age of the patient is lesser, we suspect different neurodegenerative disorder, different other neurodegenerative disorders apart from Parkinson's disease in those patients. But I would like to clear this myth that it cannot affect younger patients. It can definitely do that. So basically what happens that there is an abnormal protein that is produced inside the brain that is called as synuclein, and this protein goes and damages different neurons of the brain. And thus by damaging the neurons, it produces the deficiency of a certain chemical that I would like to describe to you in the subsequent slides, which is responsible for the clinical features. This Parkinson disease is very greatly associated with a lot of morbidity throughout the world. As the patient gets affected with this disease, their quality of life significantly reduces. The amount of effective work that they can do, they could have done in their life, reduces. And at the later part of the disease, they become bedbound. Definitely this disease is a progressive disease. It goes on, the progression, the disease progresses all throughout the life. At this point of time, we haven't had found a cure for this disease, but definitely this disease is manageable by different medications and some surgical techniques that we'll be describing in subsequent slides. So let's first see what are the risk factors. What conditions one, if the patient gets exposed to, is having a higher risk of the Parkinson's disease. So the first is cigarette smoking. So patients with who have a very long history of cigarette smoking are definitely at risk of Parkinson's disease. Next is tea intake, coffee intake. Sorry, I told tea, but it is coffee intake. So high coffee intake is also a risk factor for Parkinson's disease. Now look at these two images. One is heavy metal toxicity, and the another one is exposure to toxins like pesticides, carbon monoxide, manganese. These are certain toxins that if a person is chronically exposed, then they might go on to develop Parkinson's disease. So this heavy metal toxicity, how we can get that? Because usually heavy metals, they are deposited in the water bodies. So the people living in the rural areas, they are very much prone to this thing. So the rural population usually has a big exposure of heavy metal toxicity as well as this pesticide exposure. So they are at a risk of developing Parkinson's disease. The 10 to 15% patients of the entire Parkinson population do have a genetic predisposition. Certain genes have been discovered who are responsible for causing Parkinson's disease. We should know that if we are taking 100 patients into account, at least 15 patients will be there who will have a genetic preponderance to this disorder, because the genes are responsible for the alteration that I just mentioned, and they can lead to Parkinson's disease. 60% of the disorder is unknown. Why it happens, we don't know. That is a term we use in medical sciences, idiopathic. So majority of the Parkinson's disease cause is unknown. We don't know. They just happen. We call them as sporadic Parkinson's disease. So these are all the risk factors. And one of the risk factors I would like to mention is age. So as the aging progresses, the risk of developing Parkinson's disease also increases. So these are the few risk factors. So what happens is that uh, if we want to communicate to anybody, if we are communicating in our day-to-day lives, we communicate usually by a telephone. So telephone, they take our messages from one telephone we are communicating to another telephone. So there is a need of a transmitter which transmits the information through whatever we are talking to the different telephone. Similarly, when the information is being transferred inside the neuron, we have a transmitter. These are a group of chemicals who are responsible for transfer of information from one neuron to the other. We call them as neurotransmitter. Few of them neurotransmitters are excitatory, few of them are inhibitory, and few of them are modulatory. So the specific chemical or the specific neurotransmitter that we are describing in Parkinson's disease is called as dopamine. So dopamine is present in there is a part of the brain where it is abundantly present. It's named as basal ganglia. So there a lot of neurons are present where the chemical dopamine is being synthesized, and if the chemical dopamine is reduced, these neurons lose their activity. There is a complete loss of activity of these neurons. So dopamine is necessary. What happens in this Parkinson's disease is that there is destruction of these neurons. This neuron which produces dopamine is destroyed. So there is a state where there is dopamine deficiency essentially inside the brain. So the primary pathology, the primary cause of a Parkinson's disease is reduced production and reduced synthesis of dopamine. Not to forget, there is another neurotransmitter which gets increased once the dopamine is decreased, that is the acetylcholine. So these two chemicals are the chemicals, just we need to know that one is reduction in production of dopamine and the other one is increase in acetylcholine. Why we need to know that? Because the entire treatment is how we can increase the dopamine and how we can decrease the acetylcholine. So that way we are going to deal with this disease. So next point is what happens? What happens if this dopamine is reduced? Now, the clinical features of Parkinson's disease can be of two types. One is a motor problem where the problems are related to movement of the body, and the other part is the non-motor problems where the problems have not got nothing to do with the movements. So one part is abnormal movements and the other part is certain problems which are not related to movements, but they are related to the memory, they are related to the behavior, they are related to the blood pressure control, urinary control, etc. We'll discuss. So next point is what are the motor problems? Let's see. So I would like to show one of the videos to you, and you have to focus on the left hand of the patient. I'll just play the video. So you can see that there is a vibratory movement of the left hand of this patient. The I'll show this video again. So this vibratory movement is there. You can see that there is a more movement of the thumb and the index finger. So this is a classical Parkinson tremor. This is called as a resting tremor. The hand is seated in a resting position and there is a vibratory movement which we call in our medical terminology as tremors, and predominantly the thumb and the index finger movement is very much common. So this is a classical resting pill rolling type of tremor. It is as if a patient is moving a pill between his thumb and the index finger. So very classical feature that we see in a patient who comes to the OPD, or some of you might have seen in your relatives, is a tremor, which is a resting type of tremor. So can this tremor be seen when the patient is walking? So you can see, again, you see at the left hand, you can see that the left hand, as the patient is walking, as the patient is walking, the left hand is shaking vigorously. So we saw that it is a resting tremor, as well as it can be produced while the patient is standing, while the patient is walking. And one thing that we have to notice, that the tremor was unilateral. Unilateral means it is restricted to one side of the body. The left side of the body, the tremor was more prominent. In right side, you cannot see the tremor, only in the left side. So it very classical for a Parkinson's disease is that you have a unilateral tremor, which is both present in rest as well as in posture, and the tremor is classically a pill rolling nature of tremor. So the first clinical symptom is a asymmetrical resting and postural tremor. Let's look at the it is a tremor. First clinical feature is tremor. Now let's look at the next clinical feature. So if you can see the movement of the finger of this patient, you can see that the movement is very slow, extremely slow, extremely slow movements of the fingers. So this feature is called as hypokinesia. In our medical term, we call it as hypokinesia or bradykinesia. Hypo means slow, kinesia means movement. So it is a very slow movement that we are observing. And the next feature is, you can see the how the patient is walking. She is walking with very short steps, and she is walking very slowly. So this is a classical gait difficulty that we see in a patient. So, so what are the clinical features? One is the bradykinesia, that is the slowness. And if we examine the patient, there is a rigidity or a tightness. And the next feature is a postural or a gait difficulty. So we get four features. First feature is the tremor. Second feature is the bradykinesia. Tremor means that shivering movement that we saw, that is a tremor. Slowness is bradykinesia. Tightness, we call it in medical science as rigidity. And postural difficulty, postural or gait difficulty. These four features need to be present to call something as Parkinsonism. If these four features are present, we call it as Parkinsonism. So what can we define as a So what is the definition of a Parkinson's disease that will eventually come to? So we need four features. First is tremor, that is a shivering. The second feature is a slowness, that is a bradykinesia or a tightness. The third feature is tightness. The fourth feature is a gait difficulty. So we require this. These are the hallmark features of Parkinsonism. Now let's look at these two videos. Now you can see that again this lady, she is also walking very slowly. It was very similar to the previous video. Let's look at this gentleman. So you can see that he is also walking very slowly. Now these two people are also walking very slowly, having a gait difficulty, definitely not having a tremor, but they are also having a walking difficulty. They are also walking very slowly. So are they Parkinson's disease? Unfortunately, these patients are not Parkinson's disease. So you can have a very similar clinical features of a Parkinson's disease, but these diseases may be something else. These diseases may be something else. So what we have to see? We have to see the red flags. What are the red flags? Means what are the mimics? What are the clinical features that can be a mimic of some other disorder? They may mimic a Parkinson's disease, but they can be a part of other disorders. So what are these red flags? So first one is falls. In spite of having so much of walking difficulty in Parkinson's disease, falls are not seen very early in the disease. They are seen very late in the disease. Unprovoked falls, that is the falls that happens unexplained. Just the patient will be walking and suddenly they will fall backwards or to the front. So these are unprovoked falls. These falls can happen anytime. These falls can happen anytime in these patients, but on, but in Parkinson's disease they are very late. So if these falls occur very early, that is within the first year of the disease or the second year of the start of the disease, so that raises a question that it's not a Parkinson's disease, it might be something else. Next is if the patient is having any memory problems, which we call in our medical terminology dementia. So if the patient is having an early dementia in late phase of Parkinson's disease, after 10 years, 8 years of the disease, we can have some memory problems, but they are not very serious. But if in early stages the patient is having a lot of memory problems, or a lot of lot of difficulty in problem solving, in recognizing family members, getting lost, forgetting the directions of his house, if they are having such kind of memory problems early in the disease, then again that raises a question mark in the diagnosis of Parkinson's disease. Next, if the patient is exposed to certain kind of drugs, very commonly nowadays a lot of prokinetic drugs, means few of you might have heard the name of levosulpiride. They are given in combinations to the gastritis medicines, pantoprazole, rabeprazole, and there is a combination drug called as levosulpiride. This drug, if not given in a regulated dose, can lead to Parkinsonism. Obviously these conditions are treatable, but the unregulated use of drugs can also lead to Parkinsonism. Second category of drugs very commonly associated with Parkinsonism are psychiatric medications. So psychiatric medications again are responsible for reduction of this chemical that I highlighted previously, that is dopamine. They can reduce the dopamine production in the brain and can lead to Parkinsonism. So a patient who has a history of such kind of drug intake, so the cause is not Parkinson's disease, it is probably a drug induced Parkinsonism. The Parkinsonism is due to the drug intake. The next is a stroke. If the patient has had a stroke, there is a tendency that they might develop Parkinsonism in future. So the history of stroke should create a doubt that no, this is not a Parkinson's disease. Next, if the patient is having a abnormal body posturing, which in our medical science we call it as dystonia. Dystonia means a abnormal flexed or a extended posturing of the neck or the body. If there is a dystonia, then it creates a doubt in Parkinsonism. Next point is if the patient is having a lot of autonomic dysfunction. So just to give an idea what is autonomic dysfunction, is that if the patient is having a lot of head drilling while standing up from the lying down position, the patient will come to us with complaints that whenever I am lying down it is okay, but whenever I am standing I am feeling lightheaded, I am feeling there is a tendency to fall down, there is darkness in front of my eyes and I am falling down. So this is one feature. Next feature is that there will be urinary complaints. Sometimes there will be excessive urination. There will be a tendency to repeatedly passing the urine, or there will be difficulty in passing the urine. The patient will try to pass the urine, but he or she will not be able to pass the urine. So these kind of difficulties may be there. There can be a sudden fall in BP, blood pressure. So these are certain conditions which we combinedly call as autonomic function. So they can also be seen in a Parkinson's disease, but very late in the disease. So early presentation of these autonomic features again raise a question mark. Next point is some psychiatric features like hallucinations, delusions. The patient will come to us and say, will come to the doctor and say that I have Parkinson-like features, but apart from that, I am having visions of animals inside my room when they are not there. Some person coming to my room and talking with me, and it is not there. I am hearing some sounds of somebody talk as if he is talking into my ears, but nobody is there. So these are called as hallucinations. So these hallucinations, if again present early in the disease, they can raise a doubt. Next point is that if there is any abnormality in the MRI, if there is any abnormal MRI finding, then the doubt of Parkinson's disease is created, because in Parkinson, the MRI is mostly normal. So these are the red flags which create a doubt. So how do we diagnose them? So the first point is that in the diagnosis of Parkinsonism, one feature that we really require is the bradykinesia. Bradykinesia, as I told, is the slowness of activities. If the slowness of activities has to be there, that feature has to be there. If that feature is not there, the doubt there is a doubt of Parkinsonism. Next is the muscle rigidity, the tightness, that has to be there. Next feature is the tremor, that is the vibration of the hand that I showed in the video. The fourth feature is a postural instability. So a bradykinesia has to be there, and out of the three other features, one feature has to be there. After that, we can call that is Parkinsonism. We cannot call it as Parkinson's disorder. We can all Parkinson's disease. We cannot call it at this point. We cannot call it as Parkinson's disease. We can only call it as Parkinsonism. So how can we call it as Parkinson's disease? If these supportive features are present. So first feature is unilateral onset. While describing the tremor, I told you that if the one side is more involved than the other side, so there is a unilaterality, there is a laterality. One side is more involved, the other side is lesser involved. Next feature is a resting tremor, that has to be present, and it has to be progressive disorder. It's not like the disease is not progressing; it is static. It gradually increases with time. Next is a persistence of a asymmetry. Next, if we are giving any treatment, I have told you that dopamine is lost in this patient. So if you give dopamine, the patient should improve. So if giving dopamine, the patient is improving, then the Parkinson's disease diagnosis is nearly confirmed. Next, if we are giving large amount of medicine, so there will be some abnormal movements. These videos I will show you later. And this response to treatment should be persistent, and the clinical course should be greater than at least 10 years. So if these few features are present, at least three, along with the first few features, now we can call it as a Parkinson's disease. Before that, it is only Parkinsonism. After these are the supportive criteria. These support the diagnosis of a Parkinson's disease. After these features are present, then we can call it as Parkinson's disease. But then again, we have to rule out the red flag features that I told you previously. So the red flag features has to be ruled out. We have to be sure that the red flag features are not present. So we need a definite feature, we need a supportive feature, we don't need the red flag. And absence of a red flag, then the diagnosis of a Parkinson's disease is made. So now let's see what all come under the category of Parkinsonism. So Parkinsonism can be a idiopathic let's say that can be a Parkinson's disease. That can be some Parkinson's disease mimic, which are called as the atypical Parkinsonism. That is a very different topic. We will not discuss about that in this discussion. Next is the secondary Parkinsonism. These are the features that there is some other systemic disease, and they are presenting as Parkinsonism, but they are not Parkinson's disease. And the third part is if it is a part of some other disorder. There are certain other genetic disorders, namely the spinocerebellar ataxias, the Wilson's disease. These are few names of certain genetic disorders. They can have Parkinsonism as a part of them, but they are not Parkinson's disease. So this disorder I'm highlighting in a laser, the idiopathic or the monogenic form is the only form that we call as Parkinson's disease. Any secondary, any atypicality, or if it is a part of other genetic disease, we don't call it as Parkinson's disease. So I think a few of the medical students must be there. So certain clinical signs and symptoms I have highlighted that can give you a clue of what are the alternative diagnosis of the Parkinson's disease are there. This is a part taken from the Harrison. This is for the medical students if they are present on this discussion. So you can note it down. So if these features are present, so a possibility of other Parkinson's, the other type of atypical or the mimics of the Parkinson's disease can be thought of. So secondary Parkinson's, as I told you that there can be certain other conditions that can produce like Parkinson's disease. They can mimic a Parkinson's disease, but they are different diseases. So one of them I highlighted that if there is an unregulated drug intake, two drugs I highlighted. One is a prokinetic drugs that is very commonly used drug levosulfide and metoclopramide. These are the drugs that can lead to Parkinsonism. The second category is the antipsychotic drugs that we call as phenothiazines. They have names like haloperidol and risperidone. These group of drugs can lead to Parkinsonism. And once we stop the offending agent, that we stop the drug intake, the disease gradually improves. Next is post-infectious. There can be certain viral infections where after that the Parkinson's disease can be there, because the viral infections were affecting the brain, which in our common language we call as brain encephalitis, which we call as encephalitis. Once the encephalitis happens, they can affect any part of the brain. So after that, the Parkinsonism can be seen. Next is stroke. I highlighted previously. If there is a stroke, there can be Parkinsonism. If there is frequent head injury, so this was seen in the boxers. So the boxers previously there was not a lot of use of helmet or headgears. So there was frequent head injuries to them, and they used to develop. Went into develop Parkinsonism in their later lives. Next is the hydrocephalus. Hydrocephalus means a condition where there is a excessive fluid filled inside the brain. So that damages the brain, and Parkinsonism can be seen. So hydrocephalus means, hydro means water, cephalus means brain. So excessive fluid present inside the brain can lead to Parkinsonism. There are certain autoimmune conditions of the brain where the Parkinsonism like features can be seen. Some malignancies, brain tumors can also present like Parkinsonism. Certain endocrine disorder means the diseases like thyroid disorders, hypothyroidism, we very commonly low thyroid disease. So if there is a low production of the thyroid hormone, then they can also present like a Parkinson's disease. So these are some of the conditions that we should always rule out before making a diagnosis of a Parkinson's disease. So if any of these conditions is there, as a doctor, we always ask the patients about few of these. If you are taking any drugs, if there is a history of any brain infection, any stroke, any frequent injury to the head, we do MRIs and see that if there is no tumors inside the brain, there is no fluid accumulation, which do the various blood tests to check how the thyroid is there. So after all of these investigations, we label the patient as a Parkinson's disease. So what we see in this image is this is the iceberg, this is the tip of the iceberg, and this is the part of the iceberg that we cannot see, that is inside the water. So the clinical features that I just told to you, they are the motor features. They are the features which are associated with the movement. They become very prominent to the eyes of the clinician, to the eyes of the doctor, and even to the eyes of the patient. They come to us and tell us that there is a vibration, there is a shaking of my hand, I am slow in my activities, please do something about it. But there are some clinical features that the patient does not come to you. They don't tell that to you. These features are like hidden to us. If we don't ask them, if you have these features, they will never tell us. So these are the features which are not visible. So these are the non-motor features. So what are the non-motor features that can be seen in Parkinsonism? So one of the very common non-motor feature is loss of smell. The smell sensation is very commonly lost in the Parkinson patient. There can be a complete loss of smell, there can be some partial loss of smell. So both of the features can be present. And this is one of the feature that can be present very early in the disease. But before the appearance of this shaking, this slowness, 10 to 20 years prior to them, this loss of smell and decreased smell sensation can be seen in the patient, and they don't know why this is happening. So these features can precede actually the presence of the motor symptoms. Then there is a sleep problem. What happens in this sleep problem? The patient will enact the dream. Whatever they are seeing in the dream, they will move their hands and feet just like what they are seeing in the dream. They completely enact the dream in the bed, and they will shout, they will fall down from the bed, they might also injure the person who is sleeping next to them on the bed. So these are the sleep problems. There can be other problems like if they are not sleeping properly, there is a frequent sleep disturbance. So in daytime they will sleep a lot, they will sleep a lot in their work. So these are the sleep problems are seen. Next, very common feature is constipation. So we all know what is constipation, and this is very commonly seen in Parkinson's disease. Again, like a loss of smell, the constipation can be present years and years prior to the onset of these motor symptoms. Next feature is the cognitive features and the behavioral feature. They are the depression. Depression can be there. There can be impulse control disorder, means the patient can become very angry, very moody. They fight with their peers, that they have doubts that that the family members are trying to harm them. So these kind of psychiatric abnormalities can be there. Just I highlighted daytime sleepiness. Along with that, hallucinations can be present in the Parkinson's disease, if unless we ask the patient that, are you seeing things, are you seeing any person who is there, but your family members tell that no such person has come to you. Are you having any such doubtful imaginative appearances? We have to ask the patient, and once the patient tells us, we can adequately treat them. Then one thing is a sudden fall in blood pressure. So sudden fall in blood pressure can present that the patient will just stand up and they will say that there is a head drilling. They will sit, they will say that there is a lightheadedness. So these are the features that the patient very rarely tells us. They don't tell us. The motor features or the movement related features are so gross and so disabling for them that these features are missed. And unless we as doctor ask for these features, and the patient once gets educated that these features can also be present, they can also come and tell us, because these features can be treated. They are treated basically symptomatically. Whatever the symptom is there, we give medications accordingly, and they are controlled. So these are features which are hidden from the knowledge of the patient. They're hidden from the knowledge of the doctors also. So both of them should be aware of these features, and unless asked, these features can be missed during the evaluation. So what we are seeing from this feature is that whatever we do in the disease, we treat the patient, we don't treat the patient, the disease is going to progress. With time, the disability, you can see this curve. The disability was very less in the initial part, and the disability started rising. The compensatory mechanisms were very less in the initial part. They increase to the mid part, and as the disease progresses, they go on decreasing. So it is the rule that the disability will go on increasing. But if we identify these patients early, if we treat these patients early and properly, then we can delay the disability. We can at least lead to the point that the patient can have a healthy 20 to 30 years of life. So these disabilities can be delayed. You cannot prevent them, you cannot completely cure them, but we can definitely delay them with early diagnosis, proper medications, and timely interventions. So again, you can see that as the disease progresses, the psychosis, motor symptoms, and the physical symptoms, they go on worsening with time. So the last stage of is the stage where the assistance is required almost in every activity. The patient becomes wheelchair bound. If we don't treat a patient, this stage 5 comes in about 8 to 10 years. If we treat a patient, we have seen in some cases that they can be delayed till 20 to 30 years. So if the disease starts from 60 years of age, and we can delay the outcomes to 90 years of age, then we are giving a good enough life to the patient. So this disease is definitely not curable, but it is manageable. So this is the point I wanted to highlight. Now, how will you diagnose these patients? So one thing we have to remember, that as doctors, that the diagnosis is clinical. We have to diagnose it from the clinical features. All the tests and everything, they just help us, they just guide us, they are supportive, but they are not diagnostic. There is no test which is diagnostic in Parkinson's disease. So if we have to rely on one thing, that is the clinical presentation of the patient, how the patient is responding to treatment. These are the only two things that help us in diagnosis, nothing else. So what is the role of imaging? Most of you would go to a doctor, and the doctor will tell you that let's do an MRI. But listening to this, you will ask them that a doctor told us that it is a clinical diagnosis. So what is the role of a MRI? So why do we need a MRI? We need a MRI because of because to rule out other clinical features. Now you see in this MRI, these are all the white features. These are all the small strokes that has happened. So this is a MRI of a patient who has had a multiple strokes. So now this patient will also present like a Parkinson's disease. So once we see this kind of MRI, you know that now no, this is Parkinsonism due to stroke, not a Parkinson's disease. So this is a MRI of a patient who I was just highlighting a condition where hydrocephalus. So that is the fluid is inside the brain. So you can see that these black parts, they are very wide. So here the fluid is filled inside the brain. So this is another condition that gets diagnosed with an MRI. So this is a condition. You can see these white patches inside the MRI of this patient. These are the conditions that these are the lesions or the injuries that has happened inside the brain due to a viral disease. So post-viral condition are like this. Now here you can see there is a black line surrounding the brain in this CT scan. So this is a bleeding. So the patient has had a fall, and due to fall there is a blood has surrounded the entire brain, and this patient can also be like Parkinsonism. So the point of highlighting is that the MRI is to diagnose other diseases that can be mimics of Parkinson's disease. So that is why we need a MRI, not to diagnose a Parkinson's disease. Nowadays, a lot of nuclear imaging technologies are also coming up. You can see that here in a healthy patient, this red image was very prominent, but in the advanced disease of Parkinsonism, this red image reduces. So this is the part of the brain that is mostly damaged in the Parkinson's disease. So this is being highlighted in these nuclear images. So nuclear imaging again helps. It is supportive, but it is not diagnostic. It is not done for all the patients. It is done for select patients where the diagnosis becomes a delay. So yes, so how to treat these patients? First, what we know in this disease, the chemical called dopamine is lost. So if something is lost, we have to give it back. So we have to give that chemical back to the brain. So we have to give some medicine which will behave like dopamine, which is dopamine itself. Or we have to give a drug which can mimic dopamine, which can be like, which is not dopamine, but which can do something like dopamine, some activity similar to dopamine, and thus help the patient. So either you have to give the chemical which is completely lost, or you have to give some other chemical which behaves like the dopamine. Now if with this the treatment is not complete, then the next step is to give a drug which will facilitate the action. At least it will facilitate the action of the dopamine. So there are certain drugs that facilitate the dopamine. Whatever the dopamine is present, still present inside the brain, that action can be facilitated by certain kind of drugs. So overall, you have to increase, or you have to facilitate the action of the chemical that is lost due to the disease. So if we fail at these two steps, then let's try to prevent the metabolism of the dopamine. There are certain enzymes that metabolize the dopamine, that they destroy the dopamine. They convert the dopamine into other chemicals, and the dopamine is lost. So we have to prevent this metabolism process. So certain drugs are there which which inhibit this enzyme activity. So that is the next slide. Now I told you about another neurotransmitter that is increases. Dopamine decreases. This neurotransmitter named acetylcholine, that increases. So the next group of drugs is what you decrease that neurotransmitter. You try to increase dopamine, you try to decrease choline. That is the whole target. So the most common drug that we give to the patients is this drug. This drug where there is a combination of two medicines, that is levodopa and carbidopa. Now the levodopa is nothing but a dopamine. So the dopamine cannot be given directly, it cannot be given injectively, it can be given to a tablet where the composition is levodopa. This goes inside the brain and converts into this chemical called as dopamine and does all the activities of the dopamine. Now once you give the drug, you expect a certain response. So what is a good enough response? Once you give the drug at the adequate dose, as a doctor or as a patient, the patient will ask us, doctor, you have started medicines, but how much will I improve? How much will my life be better? So a very good response or a good response is if at least 70% improvement in the patient is there. The patient himself tells that there is more than 70% improvement. So a good response is more than 70%, but we as doctors expect at least more than 30% improvement. So that is the bare minimum percentage of improvement that we expect in a patient once you start this drug. And if you are not getting any improvement even after giving adequate dose of drug, then the diagnosis is itself at question. Because while previously telling you about how we diagnose the patient, I have told that response to treatment is very important. You had lost a chemical, you try to give a chemical, then the condition improves. So that is the whole point of this treatment. And if even after doing that the condition of the patient is not improving, then probably this is some other disease and not a Parkinson's disease. So that creates a doubt. So let's see this video. In this first video, we have not yet started the patient on medication. Just a minute. So you can let's see the movement of the patient. You see the left side of the patient. It is slow, very slow in movement. The movements are so slow. Then we gave the medicine to the patient. This medicine that we are talking about, we gave that medicine to the patient, and after 1 hour, what difference the patient has, I'll show you. Just see the movements. You can see the left hand movement. It is very slow. The patient is almost unable to do the movement properly. So let's see what happens after we start the treatment. Let's look at the left hand of the patient. You see that in comparison to previously, the left hand movement has improved. You see this hand movement, you try to see. You see, so the movement has improved. So this patient told us that there was almost a 30 to 40% or a 50% improvement previously before taking a drug and after taking a drug. So we consider that a good enough treatment. So if you diagnose early, if you start the treatment early, if you start the treatment at adequate dose, the patient will definitely improve and the quality of life improves. So, but everything is not a happy thing. Initially, we can have a honeymoon phase where the response will be very good, but as the advanced stages comes, so the response also becomes very erratic. The response either becomes very less. If you give less dose of drug, the response becomes very less, the patient becomes very slow. And if you give slightly increase the drug dose, there is a lot of side effects. So let's see. Now, this is a patient. She was having a Parkinson disease for 12 years. She was diagnosed after 6 years. Doesn't take medicine properly. Takes very less doses of medicine. So now, even after taking medicine, you see the condition of the patient. She has become so slow. You can see the facial movements, the hand movements. They are so slow. She has taken the medicine at a proper dose, but even after that, the response is very less. So once we are 12 years into the disease, even after giving the medications, 12 years into the disease, even after giving the medications at the appropriate dose, the patient will not respond very well. But if we start the treatment earlier, this response is expected to be better. So now at the advanced stage, what happens that if you are giving at a lesser dose, the response is not there. But what happens when you give at a slightly higher dose? Now let's see. So if initially you give the drug works, and this is the period where the drug effect stage. Now as the time progresses, the period of the drug effect, you can see this is the period of drug effect. Now here this is the period of drug effect. So with time it goes on decreasing, and there is a time when there is a complete dose failure. So if not given properly, and as the disease progresses, the response to the treatment also worsens. So there the only levodopa is not going to work. Only giving dopamine is not going to work. You have to add other drugs. So the dopamine agonists are these are the drugs which behave like dopamine. They are not directly dopamine, but they behave like dopamine. They are additional drugs that you can add to the patient. there will be some side effects, like there will be some abnormal movements, there will be hallucinations, there will be behavioral changes, but we have to deal with this. We have to deal by adjusting the dose. The side effects will be there, but the patient should be encouraged that you have to take the drug, or else the movement will completely go away. Next, there are certain newer modalities that are coming up, that there is a pen is also available, like the insulin, we are having pen, and there are pumps also available. So the drug that can be given by a pen or a pump is a apomorphine. Now this drug apomorphine, this is again a dopamine like drug. It is not directly dopamine, but it mimics the action of the chemical. So that can be administered by a pen and a pump. This is not very commonly available in our setup, but a lot of research is coming up, and very soon it will be also available in most parts of India. And it is a very miraculous thing, and the improvement will be very good as compared to the oral drugs. So the problem of this drug is that it cannot be given orally. Once you eat this drug, or it is taken as as something into the mouth, it is not going to work. It is only going to work if it is given as an injection. So you can see the response. Now you look at this patient. The patient, before giving the injection, the patient is so slow. There is a lot of vibration and shaking in the patient. The activities are very slow. And once you give the injection, let's see, you can see the difference. The patient's movement has become better. The vibrations and shakings have also improved. So this is a response that was recorded in this patient after giving the patient with a pen. So once this pen and these pumps are available, there is going to be a great revolution in the treatment of these patients, and the treatment will not be only restricted to oral drugs. So as I told, that there are some other drugs which also inhibit the enzymes that destroy this chemical dopamine. So this is one category of drug that can be also given if the dopamine is not working very well. The oral dopamine, levodopa, I told you, that is not working very well. So we can give these add-on drugs. These two drugs are add-on drugs that can be given once the dopamine is not working very well. So what happened? So I just told you that if the dose of dopamine is a bit less are later in the disease, so the response is very less. The patient will be very slow. They will not be able to work. But if you slightly also increase without monitoring, if you slightly increase the dose of dopamine, a condition like this develops. Let's see this video. You can see that see, this patient is having a dancing like movement. Her hands are moving here and there. She is unable to control her hands, and the tongue movement you can see slightly. Let's see this video again. The hand movements are as if she is dancing. You can see that as if the patient is dancing. So a slight increase in the dose, in the unregulated increase in the dose, can lead to these kind of side effects. So these are called as dyskinesias, means abnormal movements. Abnormal movements can be seen if there is an unregulated increase in the dose. So what I wanted to highlight is that there is a very narrow margin where we have to set the drug. If very less, the patient becomes very slow. If a slight increase, the patient starts having these abnormal movements. So our target and our focus should be to keep it at a bearable dose. So this becomes very difficult later into the disease, and this effect gets delayed. This narrow margin gets delayed uh, if we start our treatment early. So a early diagnosis and a early treatment, what it does is that these conditions, these abnormal conditions, they delay the abnormal conditions, and the patient has a better quality of life. So you can see that at once the dose is high, so the dyskinesia is there. So usually the dyskinesia or the abnormal movement is when the dose of the drug is slightly higher. So what we do in this condition, we tell the patient that you don't decrease the dose, but you take the dose in more frequent intervals. Means if you are taking a drug 3 times, you do one thing, you take that drug 6 times by decreasing the dose. You take half tablet, you take it 6 times. You don't take the drug 3 times. You make the dose as half, you break the tablet from the middle. You take it half drug and you take it 6 times. So the dose will be maintained, but there is never a peak in the drug effect. So these are the things that we advise to the patient if we want to control these dyskinetic movements. Now, this is one drug that helps. This drug is called as the amantadine, that really helps in the controlling this dyskinesia. So this is one of the drugs that helps in secretion of dopamine, but it is not exactly dopamine. It helps, and it helps in controlling this dyskinesia. This is one group of drug that can be used once there is the dyskinesia. So there is a scale that we use to monitor this patient. So this scale is called as the UPDRS, the Unified Parkinson Disease Rating Scale. This is something for the doctors. We use this to monitor the drug response, how the disease is progressing. We cannot just ask the patient how you are, and we do that. We measure the various scores. We see that the scores have increased or the scores have decreased, and we from that we know that the patient is better, is doing well, or the patient is doing worse. So from that we decide. uh, Over the times, our medical science has gone to from one step to another step. So in the last 4 to 5 years, a lot of newer drugs have also come up, which are operating at different other levels, and are also helping in the management. These drugs have been FDA approved, not very commonly used in the management. The common drugs I have highlighted, these are certain add-on drugs. They have come up, and definitely in future more drugs will be coming up. And as we have identified more number of chemicals that can be modulated inside the brain to get us a better effect. So a lot of newer drugs are in the pipeline. They will come up in the future. So it is better that we have more weapons at our armamentarium to fight this problem. So this is just to show that a lot of newer drugs are are in the pipeline, and in future we'll have a lot of newer strategies beyond the drugs that are present with us. So is the treatment limited only to drugs? No. From medications, we have gone a step ahead. We have gone to some minimally invasive therapies that can be done. So this is one of the therapies that where we can use a high frequency ultrasound, and we can produce a injury inside the brain, and we can control these symptoms. So it is MRI guided. From the MRI, we find which part of the brain to hit. Then at that part, we send a very high frequency ultrasound, and we destroy that place. Once by destroying that place, we are causing some changes in the brain that will eventually lead to controlling of all these symptoms of Parkinsonism. Now, the most revolutionary brain surgery that has helped us achieve a great success in this Parkinsonism is called as a deep brain stimulation surgery. So what happens in the deep brain stimulation surgery is that this is a electrode. This is basically a stimulator that goes inside the part of the brain that has been damaged, and this is a pacemaker that is planted inside the chest, and this pacemaker produces stimulatory stimulation. It basically stimulates this electrode, and thereby stimulates the part of the brain that has been destroyed. So this part of the brain has been destroyed. We are trying to activate it from this neurostimulator through this electrode, which is implanted inside the brain. Now there are a lot of questions, there are a lot of doubts that comes once we talk about a brain surgery. There are a lot of myths. Now we have to know that this is a minimally invasive surgery. The surgery is complete within 3 to 6 hours, and very less amount of complication. And if we choose the ideal patient for these surgeries, then we can have very good results, we can have very good outcomes. But the point is that the patient choice has to be good, the centers has to be well trained, and at this point of time these surgeries cost around 15 to 20 lakhs. So if there is any government programs, or there is any facility that can conduct these surgeries at a cheaper rate, or government is sponsoring these surgeries, then a lot of patients will be benefited from this, and a lot of good outcome can come. The point is that these surgeries are presently going on in good numbers at certain centers in India, like centers in Hyderabad, centers in Kerala, centers in South India. A lot of centers, Western India, they are being done in Mumbai. In Northern, it is done being done in lesser centers. AIMS, New Delhi is doing these surgeries. Obviously, the cost is a big problem, but these surgeries give good result. Again, these surgeries are also being done in Punjab, and they are not very damaging surgeries. The patient doesn't go into the ICU. Even during the surgery, the patient is awake, and the outcomes are very good, very manageable. Now, one question comes that if I do a surgery, can I be completely cured? No, you will not be cured. You will have a good response. The amount of drugs that you are consuming will reduce, but you will have a better quality of life, but the disease is not going to go away. And once this surgery is done, the response will be there for 10 to 15 years. So nowadays a lot of advocates have come up who are saying that early surgery is always good. But everything having been said and done, if the patient is maintaining well on drugs, if the medical treatment is good enough, then also you cannot go for a surgery. So that is one option. So other than that, what things the patient has to do better in the life, that is the dietary control. The dietary control means a lot of vegetables and fruits have to be consumed daily. And if the patient wants to have any non-vegetarian food in the diet, then it can be limited to fish. Fish can be taken multiple times a week, 2 to 3 times it can be taken. Chicken, if anybody is interested, chicken or eggs, they can be taken at least weekly once. But red meat has to be avoided. Alcohol has to be avoided. And if at all anybody wants to take red meat, that is mutton, once a month is okay. But one thing we have to remember, that a lot of green leafy vegetables and a lot of fruits, that has to be a part of the diet. Exercise is very important in Parkinson's disease. It has known to uh, be beneficial to the patient, to the extent that the drug, it helps the drugs to work properly. It is not curable, it does not reverse the disease, it doesn't do anything. If you are not taking the drugs, you are doing only exercise, then it is not going to work. Exercise along with drugs, along with the proper diet, is something that will work in cohesion. So these are a sort of few exercise poses that you can observe in the slide. So as the disease progresses, mostly the stretching exercises are the exercises that have been approved for a Parkinsonism patient. Yoga has, again, a lot of studies have come up where yoga and different yoga asanas are having a are have seen to be having very good response in Parkinsonism, and they improve the breath control, the physical strength, and everything. The mainly the breath control asanas and the physical strength improving asanas like the Tadasana, the Bhujangasana, these have been shown to have a very good scientific data is there, that they have a very good response to the response in the Parkinson patient. Very of late, different types of music therapies have also been used in the Parkinson patient. It has been seen that it has helped them in improving the movement. It has helped improving the cognition part. We have just seen the non-motor features where there is a depression, there is some dementia, there is some psychosis. So these features improve with the music therapy. So while managing the patients, we have to keep these things in mind, that they have to be advised to adopt a healthy life. They should stay active. If even if you have a disease, you have medicines, you should be encouraged to be active. You should be mobile. Cycling, running, swimming, everything has to be a part of the life. They have to be encouraged to do the various physical activities. The home should be modified such that there should not be short stools or any less number of obstacles, like usually they trip with stools. they trip on short chairs. So this should be removed, and a clear passage should be there for the patient to move. Self care has to be improved. Medication should not be forgotten, they should be taken as advised by the doctors, and if necessary the patient should be encouraged to undergo surgery if necessary. If the patient fits the ideal type that will improve with the surgery, the patient should go for a surgery if the affordability is good. Final thing is that the government and different also groups and NGOs, they should develop some groups for these Parkinson patients, that where they a different Parkinson patients will come and they will discuss about their problem. They will know how the other patient overcome a particular problem, or what are their difficulties. By sharing these difficulties, they can see that no, we are not the only one suffering. We have a lot of people, we are together. This togetherness in the society has to be imbibed, and the patient has to be shown that the society, the caregivers, and the government, all of them are worried about them and want them to improve. So this is going to be very good for the psychological improvement of the patient, and gives a new encouragement to fight the disease, because this disease, once it develops, it is going to stay with the patient till the patient dies. It never goes away. So we as a society, or the caregivers or the doctors, should be empathic towards the, we should have a high degree of empathy for the patient. We should try to encourage the patient. We should try to fill the patient with newer hope,